Thank you very much, Mr. Chairman. Now, before I start, I'd like to say that the ECTA General Assembly will take place here at 12. So if you all stay back, other people will be coming as well, so don't run away. Huh? Yeah. 12:30. 12:30, but at 12 we have to announce, because then we have half an hour officially. All right. Now, my topic today is that rectal cancer should be removed laparoscopically as compared to open surgery. Now, years ago, Steve Wexner, he did a survey and he said that only 6% of surgeons would have a laparoscopic surgery themselves. But that's years ago. This was in 1995. And 7 years after that, a survey of ASCRS and SAGES, they noted that actually 46% of surgeons do less laparoscopy than 3 years before. So it seems as if laparoscopy at that time was on a downward trend. But I think recently, with advances in instrumentation and techniques, I think laparoscopy is now again on the uptrend. Times are changing. A recent meeting last year in Taiwan, the same question was asked: what operation would you choose if you have a rectal cancer today? And perhaps we'll ask the audience here as well. Because in Taiwan, at that time, and even Steve himself said he would have laparoscopic surgery. So we have come full circle. And he then stood up and said, of course, I will choose a skilled surgeon to do it. But it's crazy. I mean, you mean in open surgery, you choose a non-skilled surgeon to do it? Of course, in everything we want a skilled surgeon. I think that's important, because I think we all have seen the benefits of surgery, and no matter what you do, technology is always better than the old-fashioned method. It's faster, it's more reliable, you can do things at a distance. Now, why are not many surgeons doing rectal cancer laparoscopically? And I think, as our friend Rasha and the other speakers before that has mentioned, some of the long-term outcomes are still uncertain, and also it's technically demanding, and it may be more expensive. And of course, there are rumors of urinary and sexual dysfunction. But let's look at the issues at hand. I mean, we don't want to use technology unreasonably, but we do want to use technology in a proper fashion. Now, I just want to bring you through some papers. I won't bring you through all the papers. It's too detailed for a 5-minute discussion. But you look at this paper in The Lancet, and laparoscopic assisted surgery for cancer of colon is as effective as open surgery. At that time, however, looking at the classic trial, the short-term results in 2005, they said that these short-term results may not justify the long-term results, because they noted that there were increased in the incidence of positive resection margins. But when they looked at their 3-year results, the classic trial at that time was the biggest trial that was available, and after 3 years, they noted that the higher positivity of circumferential resection margin did not translate into an increased incidence of local recurrence. So that was okay, but it's still only 3 years. And then when they looked at the 5-year results, they said that the use of laparoscopic surgery to maximize short-term outcomes does not compromise the long-term oncological results, because that increase in positive margins did not translate into anything significant for the patient. So that's good. And we look at some other trials. Look at the COLOR2 trial. It says that laparoscopic surgery in the treatment of rectal cancer is feasible. We don't have time to look at the breakdown, but let's just go on looking at various trials from various centers. I'm not really so much in favor of multi-center, multinational trial. The reason is because there are always good surgeons and there are always bad surgeons. And if you get a whole group of 1,000 surgeons together, everybody operates as an average surgeon. And would you trust an average surgeon to do your results? Or do your surgery? If we really want to test a system, you can get a group of the worst surgeons and do the trial and look at their results. You get a group of the best surgeons, do the trial and see their results, and you know. if you get a good surgeon, what the result is, you get a bad surgeon, what the result is. But what's the point of doing average surgeon doing the operation? It doesn't tell you anything. Okay, so I hope you get my point there, because that's very important, and many of us miss that point when we look at surgical trials. Now let's look at trials from various countries, and we see. Now this is a trial that published, this year. Laparoscopic and open surgery for middle and lower rectal cancers in China, they say, offer similar long-term results. And this, they had quite a lot, big cases. This is from South China, 113 cases in open, 113 cases in the laparoscopy. There's no difference at all in recurrence rate, in distal recurrence rate, and as well as in survival. So these are a group of people who have done a lot of cases. They say there's no difference. In Ireland, they looked at a small number of cases, but again, their laparoscopic resection for low rectal cancers is associated with excellent 4-year survival and clinical outcomes. And of course, in Hong Kong, we know this is 222 cases. Laparoscopic surgery in their hands actually was associated with more favorable survival. And we have seen that also with Professor Michael Lee's presentation earlier. In the USA, these are all very recent papers which I selected just to say that currently in this year, 2011, laparoscopic surgery generally in various countries has been said by the local surgeons to be safe and in fact have better early as well as late results compared to open surgery. Of course, here in Italy, we know that many surgeons here are very good laparoscopic surgeons with very good results. And even after neoadjuvant therapy, the results are comparable. So I don't have a pen. The results are comparable, and including 5-year survival-free and local recurrence results. Some bigger meta-analysis, this one coming out from China in medical oncology. This meta-analysis showed that a successful laparoscopic colorectal resection for colorectal cancer is as effective as open surgery. Okay, and thereby suggested that we are on the right track. We should continue on this technological frontier. Of course, as I said in the beginning of this lecture, a lot of what we do is not just a technology, but it's a surgeon. We all can take up surfboarding, but depends on whether we're agile or not agile. And of course, that learning curve is sometimes a hindrance to some of us in taking up laparoscopic surgery. And we all have that problem with the learning curve, and the learning curve may affect morbidity for the first 50 operations operated on. But so far, in all the trials reporting a learning curve, there hasn't really been an effect on oncological results, but the learning curve is very important. And that's why we emphasize things like this training conferences, and also hands-on conferences and preceptorship, because I think that's quite important. Of course, we know some of the problems associated with rectal cancer we have to recognize now, and here we see the risk factors we all know, but in this study they looked at the specific risk factors. Again, I won't go into it, but just to say that this affirms what we have always suspected about risk factors, that risk factors are worse for advanced T-stage and male sex. And of course, we know that in both sexes, especially male sex, the fatter the patient, the more technically difficult it is. The bigger the tumor, the more technically difficult, and the lower the tumor, the more difficult. So we want to choose open or laparoscopic. Which one do we choose? And we like both. We just have to have a good idea of our own technical skill. We have a good idea of the patient, his sex, the largeness of the tumor, the place of the tumor in the rectum, whether it's low, middle, or high. And then we can make a good decision about the selection of cases. Now, just a few words about cost analysis. I think the cost analysis that's been published in US or published in England may not be applicable to each and every country. And oftentimes you see that when people publish cost analysis, it's not cost to the patient. It may be cost to the country. In my practice, in a private sector, the patient is not interested in the cost to the country. He's only interested in how much I must pay or how much I'm going to lose. So when we discuss with patients, that's something that I want just to bring up, because quoting papers is often not applicable to the individual patient sitting in front of you who may be paying by insurance or who may not be paying by insurance and paying out of his own pocket. So this is something that we have to realize. So when we talk about cost analysis, the results of, for example, an analysis of the classic trial indicating that laparoscopic surgery is costing marginally more on average than open surgery, but this is only applicable to the NHS situation in the UK. In a particular situation like in mine, where patients pay out of pocket normally for surgery, laparoscopic surgery is definitely more expensive insofar as instrumentation, but when we discuss and talk about the length of hospitalization, we find that the shorter length of hospitalization more than makes up for the cost of the instrumentation, and really there's not much difference in which we choose. Of course, you know, as surgeons, we are also interested in the loss of sexual function and urinary dysfunction. And we have found, as many people in these papers, again, I don't want to go into detail, we have found that laparoscopically assisted rectal cancer is associated with a higher rate of male sexual dysfunction, but not bladder dysfunction. And this was a paper we wrote some time ago. We thought this might have to do with bulky tumors, with low tumors, with infiltration of the nerves right low down in the pelvis. But this trend is also present when analyzed with patients from a larger group. Although the Brisbane group suggested that if we have better surgery, this may be even lower. So my point today in this short sort of talk is really to say that laparoscopic rectal resection is not just possible, but it is feasible, and in fact, it is associated with improved outcome, and cost is not a big problem for us. The small incidence of urinary and sexual dysfunction does not distract from the point that laparoscopic rectal resection brings a lot of benefits for our patients. Now, we won't discuss robotic. Now, so in conclusion, really, we don't want to go back to the hand method of doing things because, as I said before, instrumentation brings a lot of benefit, and you can catch bigger fish and have a more exciting time. So thank you very much for your attention. Again, I want to just end up saying that we're going to have the next meeting in Singapore, and I just want to tell you that there's going to be great excitement there. We're going to have a lot of social events as well, which I hope will bring you to Singapore. Thank you very much.